Great. Well, thank you everybody for joining this afternoon's January educational webinar. Today we're going to be hearing from Jim Yates. Jim is the iReach Project Director at the Michigan Center for Rural Health. He's here to present to us on improving rural enrollment and access to health in healthcare to rural veterans. So I will turn this over to Jim. If you have any questions, I think we're a small group today. So if you have questions, just feel free to either put them in the chat, raise your hand, and we will address the questions as they come in.
All right, sounds good. Thank you, Amanda. Thanks for this opportunity to present this information. Always looking for ways to get this information out to especially healthcare providers, but just really anybody in the community and anybody that might be serving veterans, which is pretty much anyone that's serving the population because veterans are everywhere out there. So just real quick, I work for the Michigan Center for Rural Health, coordinating the iReach program, which is improving rural enrollment and access to healthcare for veterans and their families and their caregivers. And I also coordinate the UP Together with Veterans program, which is a suicide prevention program for rural veterans. And then just a quick overview of the Michigan Center for Rural Health, if you're not familiar with what we are. I think most of you probably are, but it was established in 1991. It's a nonprofit. Every state has a state office of rural health, and most fall under a government entity like DHHS or a university. We are an affiliate of MSU, but the Center for Rural Health is one of three nonprofit state offices of rural health in the country. And you can see all the programs that we have there. Just dealing with emergency medical services, continuing education, recruitment and retention of rural healthcare providers, and iReach down there at the bottom is the newest program. And so just a quick overview of the iReach program. Broad view of what we do. Basically, our goal is to get veterans and providers connected and connect providers such as yourselves with veteran resources so you can help us connect veterans with those resources that they're sometimes not familiar with. And of course, the big part of that is asking during screening if you, a family member, or anyone you've ever, or anyone close to you has ever served in the military, that in-process screening, and we'll cover that a bunch more later. And then also encouraging facilities and providers to join the VA Community Care Network through Optum so that you can receive referrals from the VA and then bill the VA for your services. And then, of course, like I mentioned, I coordinate the UP Together with Veterans program and also promote lots of other agency programs such as the Michigan Veterans Affairs Agency, the DHHS's Walking with Warrior program, just many others out there. There's lots of veteran programs out there, and we all just kind of coexist and offer each other referrals and collaborate on our efforts. So if there's no wrong door, no matter where for the veteran, no matter where they come, we can guide them in the right direction and get them connected. And that's what we kind of want to help you to help us get them connected and become part of that avenue to their resources. So a quick look at the veteran population, just so you have an idea of what we're looking at for numbers. Michigan is ranked, I believe, number 12 in the nation right now for the veteran population of all the states. There's over 500,000 in Michigan. And less than half nationwide are connected to all their earned benefits. And that's the purpose for a lot of these programs, just getting them connected. And also want to point out that most are receiving health care at a non-VA facility. And I put that out there to dispel any misunderstanding that there might be that all veterans are taken care of by the VA at a VA facility, and that's just simply not true. A majority of veterans, especially in the rural area, receive care in the community just because of the travel distance to a VA healthcare facility. And then some use a combination of VA and VA referred community care, of course, and then some use community care only. And of course, there are those ones that just use the VA only. But not all veterans are even eligible for VA healthcare as well. Though new legislation the past couple of years has made a lot more veterans eligible that weren't previously. And just to give you a rough idea, the split for the VA and community care, what they would like to see is that The VA would like to provide 60% of the service and then, refer out 40%. Well, I believe that's where they're at now, 60/40. They'd like to be 70/30 because, of course, like any other business, they want to have increased volume. But they're right now about 60/40. The Iron Mountain VA would be happy with 50/50 from what they've told me, just because they realize they're so rural. As a matter of fact, the Iron Mountain VA is considered the most rural VA medical center in the country. And so they realize that distance and to care and the care that they're able to provide, they're just not going to be able to serve 60 or 70%. So they're happy with 50/50, which means there's that many more veterans in these remote rural areas that need to be seen, through a community care provider such as yourselves. And then another look at the kind of a graph here. Michigan veterans tend to be older than the general population, and that's for the most part nationwide. But most Michigan veterans are over 65. That's 52% are over 65 years old, with nearly one-third being over 75. So definitely an older population. And you can see some of the eras that they served. We still have a lot of, obviously, the Vietnam veterans are the majority. At one time, of course, the World War II and Korean War veterans were way up their numbers, but of course, they're aging out. And another graph of Michigan veteran population. So less populated counties in Michigan have a higher share of veterans, especially in the northern, lower peninsula, and of course up in the UP. The national percentage for veterans is about 5%. Michigan is about 6%. And you can see these counties, especially the darker green you get, the higher percentage there is, all the way up anywhere from 13 to 16%, which is more than double the national and Michigan average in some of these rural counties. And just want to give a quick overview of what we call the VA. There are three separate administrations under the VA, and though they're all related, there's a distinct separation between them. And even between the VHA and the VBA, which you would think would be more directly connected, because, of course, all of these are benefits, but they have a separate benefits administration. And even the VA admits there should be better communication between the two. A veteran could be eligible or enrolled in one and not the other. They could be enrolled in healthcare but not getting the other benefits. They could be enrolled in the benefits side and then for some reason not be enrolled in healthcare. I think they're trying to ensure that that doesn't happen as often as it is, but in the meantime, we still need to watch for that. And the VHA is the largest integrated healthcare system in the U.S. and makes up 95% of the VA when you talk about employees, buildings, budget, et cetera. And that's why, especially in this healthcare field that we work in, that you work in, when you hear VA, you're pretty much always thinking VHA, the healthcare side of it, because that is the largest portion. We've got medical centers around Michigan. We've got the clinics that fall under the medical centers scattered throughout. They're trying to cover all the areas. But when it comes to VBA, the regional locations are Detroit and Milwaukee. So there's not as many of them, and hence the VHA makes up 95%. Now, of course, and we'll cover this more, but there are veteran county service officers that work on those VBA parts, and they also, of course, help out with enrollment in healthcare as well. And so there is those folks out there that can help out with all these benefits. But the big overall picture of the VA, kind of a breakdown there. So there's lots of programs, like I say, the largest healthcare system in the US. And so there's lots of programs within it. And so just want to put that out there to emphasize to not get frustrated or wonder if someone doesn't know their job if they don't know a specific question, because there's no way that anyone can know all the facets of all the different programs that there are. And that's why sometimes it takes a little bit of effort to get narrowed down to who it is you're looking for to ask that specific question for a certain situation. And of course, it's a federal program, so there's some bureaucracy and complications in that as well. Back to that focus of what iReach is doing. Our main or at least one focus is asking care facilities and any providers, such as yourselves, to screen for military service at all intake points. Because for the care facility and veterans to take full advantage of the resources offered through veteran programs, it's important to first identify the veteran. And so there's many advantages of identifying veterans for the provider. And of course, then it also is going to benefit the veteran and their family as well. And you can read through all these. I'm not a slide reader, but I like to put that out there so you can read it. And then, of course, when the slide deck is shared, you'll be able to go back and reference it as well. But lots of benefits to it. And of course, veterans have unique healthcare needs, disease patterns, and cultural backgrounds. So that's part of it. And if the provider knows about that patient's military affiliation, they can build rapport and diagnose and treat veterans more effectively. And we'll look at a couple of those possible exposures and common medical conditions associated with military service. So there's a very short abbreviated list there. But for example, veterans are twice as likely to develop ALS in comparison to those who have not served in the military. And then just a short list of some of the other exposures and experiences that are unique to veterans. And so on that note, I want to talk about presumptive conditions for a minute, and kind of the definition of a service-connected disability. And that is an injury or disease that was caused by or worsened by military service. These disabilities can affect both the mind and the body. And in most cases, a veteran needs to prove that their condition was, more than likely than not, caused by their service. So they have to prove it somehow. But for presumptive conditions, the VA automatically presumes that certain disabilities were caused by military service. And this happens when sufficient evidence is found to support a link between an exposure factor and a condition. So in other words, if a service member was in a certain place at a certain time and has a certain condition, it's automatically a service-connected condition if it's on the presumptive condition list. And so unfortunately, if you think about it, sufficient evidence means that many service members that served in a certain place at a certain time have already been diagnosed with a certain condition. And so then it ends up on the presumptive condition list after it goes through all the approval processes. And I got 3 slides of all the presumptive conditions. This isn't all of them. There's 200, and the list continues to be added to as they come in. So here's an example of how that kind of works. You may have heard about the contaminated water at Camp Lejeune. That's the popular news story because it's a class action lawsuit and made the news, but there's plenty of other exposures and contaminants out there. That just happens to be the one in the news because there's opportunity for claim sharks to capture some of that money. So you're seeing all the commercials for it. So I was recently speaking with a provider who many, many years ago went out of his way to help a veteran. He diagnosed this patient with esophagus cancer, and somewhere in the screening process identified that that patient had served at Camp Lejeune. And at that time, not many people had heard about that contaminated water. Like I say, that was many, many years ago. But the provider did some research, learned about that, and then found a link between exposure and condition because he knew that this was just an odd thing for a person of this age to have and wondered why he had it. And so then he found that link between exposure and condition and got that veteran connected with the VA. And so the veteran could receive no-cost health care and disability compensation. And like I say, these aren't all the presumptive conditions, but just want to note that that story highlights how providers can play a key role in identifying trends in veteran health conditions, which could impact future legislation such as the recent PACT Act, which is big news, and we'll cover that briefly a little bit later. So back to the screening process then, kind of set the stage for that and the importance of it. And so in screening for military affiliation, it's important to ask the question in a manner that allows everyone who has worn the uniform to feel included in the question. And because for various reasons, not all who have served identify as a veteran. And I didn't know that until I started this position, almost 3 years ago now. Um, and I was unaware of that. That's not everybody that served identifies as a veteran. There's different reasons for that. Sometimes they don't want to be affiliated with that term. Sometimes they just don't think that they are because they didn't serve in combat, didn't get wounded. So we want to ask that question in a manner that's more inclusive. And family and household members need to be included in the question as well. So therefore, that's why we recommend that have you, a family member, or anyone close to you ever served in the military, because that's a better and more inclusive question. And as you can see, it just allows others to identify veterans as well. And in a minute, I'll share some success stories that are good examples of why, this is important to ask it a certain way. And when someone does identify as having served, we have a toolkit for providers to assist them with next steps and referrals, because that's the question, like, okay, they say they are, then what do we do? So in that toolkit, and I'll explain it a little bit later here as well, we'll give you some guidance on what to do then. And of course, lots of other resources on our Center for Rural Health website as well, on the Veterans page. And just real quick, want to note that those providing care or assistance may not identify as caregivers either. We've been finding that out. Even though the care they're providing might qualify them for caregiver assistance because there are VA programs out there and other programs that help caregivers. So that question would also need to be framed properly as well if you're, looking for the potential that someone's providing care to a veteran. Because the average person hasn't gone to school for it. They don't have a certificate saying they're a caregiver. They're just a family member of somebody that just happens to have picked up that role and helping out. So some data here on the properly screening. So we emphasize the positive impact that properly screening for military service can have on the veteran, their family, and the facility. So here's a couple examples. A facility in Iowa thought they were serving about 50 veterans, and that just came from intermittent screening. They looked at the type of insurance the patient was using, such as, VA TRICARE or CHAMP VA, or maybe they had a VA health care card. But like I say, not everyone's enrolled, not everybody's eligible. But maybe the patient self-reported, maybe they had a ball cap on, some other passive way of identification. So they thought they were serving about 55 veterans through those means. Then they began properly screening for veteran status for everybody that's coming into the facility. And in not too long of a time, they found out they're serving over 550 veterans. And then the Baraga County Memorial Hospital started the same program. They gave an estimate of thinking they were serving about 60 veterans, and they quickly found out the numbers kept rolling in. First, it was 390 within a few months. The number I have up there is 527. I guess I need to update that because my notes say the last that they brought in was 587. So uh, they're identifying a lot. About half of them have requested to see the veteran coordinator that we've established in that facility to get more follow-up information on their benefits. And so, of course, beyond the positive impact it's had on those veterans and getting connected with other resources they were unaware of, it also improved the facility's needs assessment effort and gave a more accurate patient characteristic report to the UDS and assisted with patient payments because in some cases the patient wasn't able to pay for services. They found out you're a veteran, you should be enrolled in VA healthcare. We can then provide this service for you and bill the VA, and then they get recouped for funds that they previously, in some cases, were just writing off because they were, like many healthcare facilities, kindness to their heart, they served the person, but then maybe didn't receive all the payment they could have been getting. And then some more data, and when we take a look at identifying veterans and their families and how they can help address unmet needs, this data here was collected during the UPCAPS, which is Upper Peninsula Commission on Area Progress, which is an aging service up here in the UP. During a food card application intake program, they would call in to sign up for a food card. And when they called 211, 211 would screen them out for other unmet needs. And this is the data that was driven off or gathered through that. So you can see, let's see, how many, there was 2,000 called in, 2,100, and then 1,366 responded to having some sort of unmet need that they could use some help with. And you can see the breakdown there. The number one need was home repairs. And then after that was dental. So dental's always a gap for veterans, and we're working on some things to try to close that gap. And then there's utilities assistance, and you can see some of the other kind of social drivers of health there and the gaps that were identified. And then here's another similar survey that was done. And this was through that same program down in Iowa City. And you can see that from their intake, the VA healthcare enrollment was one of their number one needs. And then some of the other ones there, housing and utilities, transportation. And so those are just some of the ways that, screening for veteran status and asking if they have any other unmet needs, depending on your capacity to be able to do that in your facility, or just that quick referral. And like I say, we'll cover that here in a second. So a couple success stories of these programs. These are real life situations where providers played a key role in assisting veterans and their family members. That first story, a woman's 92 years young, and she acknowledged being a veteran and was given some in-home care needs assistance. And then another one where a Navy veteran was in hospice care. Unfortunately, exposure to asbestos is too common on those old Navy ships. And so he had never applied for anything, but now he's in hospice due to that service-connected disability. So they hurried up and got him enrolled. And then after he passed away, his widow received a pension based on his disability. The next one, an older woman acknowledged being a military widow, and she was given some assistance and saved her quite a few $100s a month, which was a lot for her. And so kind of use these examples. Here's three of them. These three examples, they're all is 92 years old, already in hospice care, a widow that should have been connected up with her benefits much earlier. The 92-year-old lady should have been, we don't want to wait till they're 92 to finally get them connected, or in hospice care. In all these cases, they could have been receiving these benefits and had a, better quality of life and situation had they been identified and connected earlier. And then also back to asking that question in the proper way and including family members. If we had asked, are you a veteran? How many of these three would have responded? Probably none. Because even the woman that was the one veteran in the situation may not identify as being a veteran, especially being 92 years young. So we want to frame that properly and make sure that we're including the family members and helping others to identify the veterans, such as in the hospice situation. So some more success stories there, a little more narrative there if you want to read it real quick. But these stories highlight the importance of follow-on screening and either in-house assistance or assistance through a referral, like I say, depending on what your capacity is able to do. So a couple things to point out in these two success stories is that the woman there that has a 10% service-connected disability, which is through the VBA. You remember the VBA and the VHA, they're one of those first slides. She got, by identifying that she was 10% service connected, they said, well, why aren't you enrolled in the healthcare? So they got her enrolled in the VHA. She should have already been enrolled, but for whatever reason wasn't. And then that last scenario there where the veteran that called into the facility probably did so because he heard about the high quality service provided to veterans at that facility because there was a veteran coordinator in that facility. And so that's just a great example of how the facility can benefit as well, increasing that volume and enrollment. They got his care switched over to that facility and he's going there now. Okay, and then just real quick again with the family benefits and that they may be eligible for some VA benefits as well. And these can be used to get an education, provide supplementary income, get a VA guaranteed home loan, assist with healthcare needs, etc. Lots of programs out there for the spouses, dependents, survivors of veterans. So we want to make sure we always include them in the conversation. And then more information here on the, like I say, there's lots of benefits, and then just to kind of focus on the healthcare benefits, there's the civilian health and medical program, and that's through the Department of Veterans Affairs, CHAMP VA, and that's a VA health benefits program for spouses, dependents, survivors of veterans who meet certain service-connected disability requirements. So, of course, it's not for everyone. And those that don't qualify for TRICARE might be eligible for CHAMP VA. And TRICARE is a DoD or Department of Defense healthcare program for those that are in uniform already, serving, active duty and retirees and their families. So a couple different programs out there. And also family members may be eligible for certain benefits through programs such as the Spina Bifida linked to Agent Orange, Children of Women Vietnam Veterans, Camp Lejeune families, the VA Caregiver Support Program. There's vet centers also out there. So lots of different programs, and some are specific towards certain conditions and certain situations. So the next steps and guidance for when someone does identify as a veteran. So at a minimum, we just ask that you offer federal, state, or local VA contact information. But directly helping them connect with a veteran service officer is actually preferred because that's kind of that warm handoff that we would prefer, because if they're not already connected by going online or calling the 1-800 number, they may not do that even if you offer that information to them. And then, of course, like I've kind of alluded to, when possible, further screening is recommended so you can provide more direct, relevant referrals and information to them. And of course, these follow-on screening questions align with, those social drivers of health, like those graphs that we showed, those unmet needs. And like I say, there's toolkits and training available to assist with these next steps. So looking at some of those barriers on the left there, I kind of have the enrollment barriers that we've identified, and then the corresponding how to breach those barriers directly across from it. So awareness is the number one barrier. They're just not aware of the different programs that are out there. They may have been denied. I know I just talked to a veteran not too long ago. He was denied by the VA in 1968 when he got out of Vietnam, and he hasn't been back since. Just okay, he'd never, and you can't blame them because of the way they were treated when they returned. Um, and a lot of things have changed since then, and they're not aware of the new legislation and new programs. So that's where our outreach is um, helping to fill that gap. And so, like I say, there's that barrier and then the corresponding how to breach them. And how to get started is also one of the key barriers. So that's where we hope that you can help them out, making them aware of it. And here's how you can get started. And so those key elements to breaching those barriers are friends, family, providers, advocates, veteran and community organizations, Legions, VFWs, Elks, Moose, Eagles, all those folks. And sometimes veterans are just not interested or they're being unselfish. And we may be able to overcome that indifference by assuring them there is sufficient funding. As a matter of fact, the more that are enrolled in the programs, the more funding there will be. And then we can also ask them if they would give up any other earned benefits that they paid into. One example I use is Social Security. They paid into that. Would they just be like, I don't want to take that away from someone else, so just not, engage in that. So probably not. And then also, there's just that apathy or indifference. And they could do that for their spouse or family member, um, even if they don't do it for them. If they don't do it for themselves, do it for their spouse or family member, because they may not need it now or be eligible for services now, but they can still enroll and have it in place for later in case their health status or other health coverage or other life situations change. And I kind of have another slide here on that. So like I said, there's many reasons a veteran should enroll in VA healthcare and file a claim, two separate things. One's VHA and the other is VBA. And these align with breaching those barriers to accessing those resources, like I noted earlier. So there's 5 of them, and then here's another one. I just keep adding these bullets as I go out and talk, and I get feedback from people and say, well, this might be another good reason. So I just keep adding to this list. I think about a year ago, I had about 4 bullet points. Now I'm up to, looks like about, almost 10 of them there now. So just more and more reasons I keep accumulating to get that information out to help overcome that indifference. And I put that out there so you can use these bullet points to, help veterans overcome their indifference in applying for benefits. Lots of good reasons why they should. And then ways that they can enroll in healthcare and file a claim. There's a few ways they can do it, and having an accredited veteran service officer help them is usually recommended. And that's through that county VA. And there's one in every county. And here's how they can be reached. It's easy to find a local veteran service officer. Just real quick, you might also hear VSO, meaning the Veteran Service Organization. That'd be the Legions, VFWs, DAVs, Disabled American Veterans, Marine Corps Leagues. So VSO can mean two separate things, but we're talking about the service officers that help veterans file their claims. And or they can just dial 1-800-MISH-VET. That's usually a pretty good, easy number to remember. And just wanted to cover the VA healthcare priority groups real quick, just because you may hear that different veterans are getting different services. Some are eligible, some are not, but it seems like they had similar backgrounds, similar military service. So why is one getting one thing and one the other? But it can get kind of complicated, and you don't need to worry about how that works. But just wanted to let you know there are different priority groups. So once they get enrolled in a VA healthcare, they may be enrolled but not really eligible for anything at that time. But it's still good to get enrolled in case they do need it for later and they become eligible. So they put them in a priority group of 1 to 8. The priority group may affect how much, if anything, the cost of care will be. And the groups are based on military service history, disability rating, income level, and whether the veteran is qualified for Medicaid and other benefits such as the VA pension benefits through the VBA. And of course, those with service-connected disabilities have the highest priority, and the lowest priority are veterans having a higher income and no service-connected disability. And so that PACT Act that I mentioned earlier, that's the Promise to Address Comprehensive Toxins Act of 2022. That's big news in the veteran community, and as of March 5th of last year, most veterans are eligible for VA health care. Like I say, they might be priority 8 and not really be getting anything, but they should still enroll. But most are eligible for something, maybe somewhere in that mid-priority groups. And so, of course, 1/3 of veterans, as noted earlier, are, and sometimes in rural areas even more, are being served in the community, getting their care in the community. So now there's going to be even more enrolled and more receiving care because now they're eligible to have it paid for potentially. And so there'll just be an increase in volume. So now more than ever, more in-network providers are needed because like most healthcare organizations, the VA is short-handed and the distance to the nearest VA facility can be a barrier as well. So we just want to have more facilities and more providers in enrolled in the VA Community Care Network so they can serve veterans and then, build the VA for that. And every VA medical staff has staff dedicated to care in the community. And so connect with them if you haven't already been connected. And I just kind of left this slide on here. I put this together for another specific presentation, but thought it was worth just leaving on here. Some specific resources for substance use disorders and the resources available to veterans. I briefly mentioned the Walking with Warriors earlier, the DHHS Veteran Navigators. They focus on, they're a little different than the VSO, where the VSO is helping them file claims. The Veteran Navigators are helping them. Mhm. There, was there a question or a sneeze? Um, so the veteran navigators are there to just assist folks that are in mental health crises, having an SUD situation, helping them, and they work very closely with the veteran service officers. But they are more connected with the mental health facilities and things like that. The veteran navigators would be more likely to answer the phone after 5 o'clock on a weekday or on a weekend to go and help out someone, after hours. Whereas the veteran service officers are already pretty booked day to day. uh, helping out veterans filing claims, working their sometimes limited uh, schedule, depending on how much funding they get from the county. So the Veteran Navigator is another great resource for those specific situations. And then, of course, the Veterans Health Administration has programs for SUD as well. But like I haven't read there, to access these services, they have to first apply for VA health care. So wouldn't it be nice if they're already enrolled? And so if they have a situation where they need to have some sort of immediate care or whatever it may be, that they're already enrolled and can receive that care. And then there's some online resources there. I like Make the Connection because they can um, uh, search videos and find stories from folks that served at the same time that person did. They can filter it down to find stories that are relative to their experience. And then Psych Armor has a lot of great resources out there beyond, those two that are listed there for SUD. They have what says 250 or more military, cultural, educational products. Just short videos, basically. Most of them are 10 to 15 minutes or less on specific topics within the veteran and providing services for them. And that is our, well, one more slide here. So we're just real quick, we want to make sure that we're connecting service members and veterans and their families and their caregivers with the care and services and well-being activities. So you got the warriors there on the left. We're in the middle and trying to connect them up with you folks there on the right, the healthcare facilities, get them that care and service that they've earned and deserve. And now there's our contact information. We have the website and Twitter and Facebook links, and our website has many resources, educational videos, and much more related to veterans care. So if you want to go on there and access more in-depth information, it's all right there. And so now we can, I don't know if there's any questions in the chat or if we want to just open up the mics for any questions anyone may have.
There's no current questions in the chat, so now would be a great time to raise your hand or just come off of mute to ask Jim any questions that you might have.
See some familiar faces. You would just, I'm not sure if that's how you pronounce your name, but we just had some email communication. We're going to be getting connected here soon.
Well, if there aren't any questions, I want to thank everybody for joining today. And also, Jim, thank you for presenting to the group. We greatly appreciate it. If there are, oh, sorry, I see one question. Jessica Baker says, do you have any marketing materials we could pass along to the veterans with some information by chance?
Yeah, absolutely. I need to drop some off to you. I'm glad to see Jessica was able to join us. I have quite some brochures that I've made. Matter of fact, Jessica, let's connect. I will be coming through that area tomorrow. If you're going to be, and I can drop some stuff off.
All right. She said that'd be wonderful. She'll email you.
All right.
Well, again, I just want to thank everybody for joining. You know, Tammy just said great job, some very important information that you shared that she was aware of. So thank you. So again, thank you everyone for joining. I will be sending out a survey at the end this afternoon for you to fill out. If you could do that, I would appreciate it. And then the slides and video recording of this webinar will be up on the website within the next couple of days. So thank you again. Thank you, Jim. I appreciate it. And I will give you all back the remainder of your afternoon.
Well, thank you again for this opportunity. And yeah, feel free to reach out if you have any questions.
Perfect. All right. Thanks, everyone.